So now we're going to go to the other side of the little chart. So remember, this was osseous primary tumors or osseous metastatic disease. And that's kind of where this extradural fits in. So this is, I'm just going to tell you, this was metastatic Neurosurgery, I believe. But you can see how beautiful this picture is, looking just like this figure. I love that just for that reason. So the cord is being compressed. It's not expanded. It's not parenchymal. It isn't within the dura. In that case, the dura would be coming straight down behind it. So it's not that intradural extramedullary. In this case, it is truly extradural. And this is the dura, this black line coming down behind. So CSF, spinal cord, CSF, dura. And it's being pushed forward by this tumor, which is extending from the posterior elements of the spine, the osseous components of the spine. And it's kind of epidural extension, basically cord compression from an extradural mass. So it's compressing the cord there. So extradural osseous mets, 80 to 95% of everything you're going to see. But we also, just for the sake of categorization, put multiple myeloma and primary bone tumors in that. So this is multiple myeloma. I'm not going to go into that because it's not a surgical disease, so we'll skip over that. Primary bone tumors. This is a plasmacytoma. So 5, 4, 3, 2, 1. This vertebral body is abnormal. You see these black things in it. Black cortex, draw a black line. Black things in the middle mean that's also a different type of bone. So this mass has been growing forever because the mass is replacing normal bone marrow. The struts that hold up a vertebral body, the trabecula, have to get bigger to support the vertebral body's, the pressure on it from above for gravity. So the trabeculae get expanded, and that's what causes this very unique appearance of a plasmacytoma. This is an axial.
Wendy, can you comment on the disc space involvement with tumor versus infection? This is a nice picture here.
So disc space?
Yeah.
Disc. So the only tumor which will cross a disc space is a chordoma. There are no other tumors which will involve disc. So if you've got disc involvement, unless it's chordoma, it's not a tumor.
Exactly.
Like that? How's that?
For the listeners, if you see the discs very well preserved, it often means that's, and you're wondering infection versus cancer. It's usually cancer. Cancer usually preserves the disc spaces versus tumor, which is infection, which will involve the discs.
Nice, unless it's chordoma, which I see all the time, but nobody else will ever see. So okay. Oh, did I go too far? Oh, I just put this in because this is another plasmacytoma. So plasmacytoma, if you've studied this yet, you know that oftentimes if it's a solitary tumor of plasma cell disorder, it's plasmacytoma. If it's multiple, then it's myeloma. So they're very similar. In this case, though, these past two cases, this was the only tumor in the body. So those are considered primary tumors and treated as solitary tumors for en bloc resection. Or if they're treated that way, sorry, if they're treated surgically. So this one's L4. This one has collapse. The posterior cortex is going back into the canal. It's compressing the cauda equina, giving this person symptoms. This is really old picture, but this is a post-contrast. You can see it's all enhancing. The bone is expanded, more than destroyed. A lot of tumors that are very aggressive, fast-growing, like renal cell carcinoma, will destroy the bone. And very few tumors actually expand it, but the primary bone tumors are more often expansile. This is a CT, and again, you can see that trabecular thickening. It's not like primitive, like it's being eaten, whether it's by infection or tumor. It's more like it's being very slowly remodeled, and those trabeculae are getting bigger as the soft tissue of the tumor replaces the normal marrow. And here's another CT. All right, so those are the main bone tumors. And again, I just want to go through this part quickly because these are the ones, I mean, you'll see them, but again, not anything like metastatic disease. This one is with this is an axial. It's kind of hard not seeing all the images, but I didn't want to spend too much time on them. This is an axial T2. And you'll see all these little like locules with different, like bright on the top, dark on the bottom. And these are hemorrhage levels. So there's blood and fluid in these. So a bunch of fluid levels. This is an aneurysmal bone cyst. Maybe, can you talk about that, Jonathan, a little bit about those? Just because they're kind of cool. That's probably the coolest of all these, except for
these are a little bit weird. Aneurysmal bone cysts, or ABCs. They are very hemorrhagic primary tumors of the bone. This is a great picture, by the way. I like this MRI a lot. I'm kind of I just keep staring at it. But if you CAT scans are also interesting as well too. They have this kind of soap bubble appearance, or like it's a very characteristic appearance on CAT scan. These guys have actually, my first experience with aneurysmal bone cyst is one that actually ruptured in a young patient and caused an epidural hematoma in the mid-thoracic spine, and the patient needed emergent surgery. So these things are not like, they're technically benign, as in they don't metastasize to other parts of the spine, but they can behave very, very badly. So these are, they're, if and when possible, to remove these safely in a patient who has one, they're generally good to take out if possible. But there is room for surveillance on these things. You can watch them if they're small and asymptomatic. They were found incidentally. You can watch these.
Yeah, and that's the issue, is that these, I mean, there's basically no normal bone there. And so I wish I had a sagittal on this one, but there's nothing, and you can imagine it's like an eggshell. That thing could crack at any time. So they are problematic, and you do have to probably, when you do your surgery, you have to probably replace it with something, right? We'd have to put something in that defect to keep your spine normal height, maybe. And that's for another time too, probably. All right, next one is, this is a chordoma. Again, this is the only tumor that would cross a disc space. Chordomas are a little bit unusual. So sagittal T1, it's dark. This is, I guess, sagittal T2, maybe. I'm not sure what that is, actually. Maybe that's just showing a different angle. This is a different kind of T2, which is taking out all the fluid. This is a fat-saturated T2, very bright. So chordomas are very, very bright on T2. They may not enhance avidly. So that's how you know, again, this is something you'll learn later when you do your radiology rotation. These can be at the skull base. They can be cervical, thoracic, lumbar, spine, notochordal remnants. I love chordomas because they're fascinating. They're horrible tumors because, as you can see, like, this is replacing the entire sacrum. This person's got to get a sacrectomy, and you know all the nerves that are coming out of the levels, you know, the sacral levels, and those are important nerves that have important effects. They control important functions, and maybe Jonathan, you can talk about that. But these are things we biopsy all the time. You want to, when we biopsy these, we have to mark the track where we went, because they can seed and have tumor deposits grow along the track of your needle. Surgeons usually, not always these days, but usually do an en bloc resection, followed by some kind of a radiation, proton, or gamma knife therapy at the bed. Do you want to say anything about these?
These are the mother of all tumors. These are the most difficult surgically to take out, with the highest stakes. These are tumors that should be handled at a center that is experienced with taking these things out. It should not be done in a place that does one a year. These should be done at a cancer center that has all the multidisciplinary and all the physicians and surgeons are able to and experienced to take these tumors out, because there's so much that can go wrong, and to really to achieve long-term remission and control is extremely difficult. These are the cases that you read about or you see like in the news where it's like a multi-day, or one of these like 30-hour surgeries with 15 different teams, front, back, front, back, back, front. These are very, very challenging cases.
Yeah, and when you have your breakout sessions after we're done, maybe John Shin will show cases. I hope so, because he does these tumors.
Yes.
For sure. And he's doing the tumor section, so hopefully he'll show a case.
Yes. All
right, chondrosarcoma, just quickly, heterogeneous enhancement in this last picture, which is the post-contrast fat sat. Pretty much all tumors, they kind of look similar. So they should be T2 somewhat bright, T1 hypointense. This one, it doesn't enhance avidly because it's got all the, it's got other cartilaginous components and other components in it. But just because it's not avidly enhancing doesn't mean it's not a tumor and a bad one. This is a cool one. I wish I could show you more, but maybe some other day. This one, okay, so osteoid, osteoma, or if it gets to a certain size, osteoblastoma. Young patient, pain at night, has this sclerotic focus right here at the kind of the intersection of the lamina and the pedicle. And here you can see it on the sagittal right here. On MRI, he's got edema around it. It's this black focus right here, black focus right here. So I don't think surgeons always treat these. We can treat these actually with radiofrequency ablation. So I would go in there and put this frequency probe in and burn it and actually kill that tumor, and that can relieve the pain. Or, you know, if it's an osteoblastoma, or maybe surgeons would just go ahead and treat it as well if it wasn't amenable to a percutaneous approach from radiology. Yeah. Okay.
Yep.
This one
of the things, if they ask you a question about that, is responsiveness to I forget if it's aspirin or NSAID.
Yeah, that's the board question, right? I think it's you take NSAIDs for it.
Yeah.
Yeah.
So either aspirin or NSAIDs. I don't remember.
I'm sure somebody in the chat can tell us the answer to that. They'll know. They'll remember.
That's the buzzword there.
That's the board question. Yeah. Okay, so lymphoma. So this is a little bit different category. You know, not quite primary bone, but it is primary bone in a way. So here's our sagittal images, post contrast in the middle. You can see this big enhancing collection back here. This is the spinal cord, big enhancing collection behind the spinal cord. You know, if you saw this and didn't have any history, you might say, okay, is it an infection? Is it a huge epidural abscess? Is it a big epidural hemorrhage? And it's actually soft tissue, and this is a patient with known lymphoma, and you would usually know the person has lymphoma. Down here on this axil at the bottom, you can see lymphoma kind of it's coming out of the bone, but it's circumferentially engulfing kind of the thecal sac in the epidural space and compressing the thecal sac, even though there's not cord compression. Let's see what else we got here. Oh, this is another case. So this was super subtle. So we were doing, so I do a lot of intrathecal chemotherapy. And where I was before, they didn't ever get MRIs because there was no MRI in the cancer hospital. I shouldn't say that, but there wasn't and there isn't. So we would just do lumbar punctures for putting in chemotherapy for patients with leukemia and lymphoma. And there was this one patient, and we do them, some people get it 3 times a week. Some people get it once a week. Some people get it once every month, whatever. This guy kept getting harder and harder. We put in the needle. You know, at first there's a lot of cerebrospinal fluid coming out. Next time, not as much. Next time, not as much. And it started hurting him more and more too. And it wasn't the technique, of course. The lumbar puncture itself was perfect. But we finally said, something's going on here. We're not getting CSF. You please bring the patient over to the other hospital to get an MRI. You can actually see it on this myelogram, but in retrospect, actually you probably see it prospectively, you're looking for it. But there's some little, this is a contrast MRI. There's dense stuff. Actually, this is non-contrast, sorry. There's stuff around here which is dense, which that corresponds with this soft tissue around the thecal sac. So cerebrospinal fluid is bright, is the white stuff. Little nerve roots of the cauda equina in the middle. This black line, this is thecal sac, and all this soft tissue is lymphoma compressed in the thecal sac. So you can see why when we tried to do our lumbar puncture, we weren't getting any fluid out because there's none left because it's being compressed. And this is the sagittal MR for that poor guy. And he has both osseous disease as well as extradural disease in the canal itself, compressing the cord.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.